Okay, I think we are online and we're ready to go here. So we can get started. Good morning. I'm John Casper with the Oshkosh Chamber, and our pleasure again to host our weekly virtual town hall. Excellent topic today. Something that's on everybody's mind in terms of the current situation with COVID-19. We have several people on the call, and just remind everybody that they are muted, but we will have an opportunity for Q&A at the end of the presentation. So if you have a question you'd like to submit, you can go to the tab on the bottom of the screen where it says Q&A and submit that, and I'll go through those and I'll ask those questions. So we do have two distinguished guests with us today, Dr. John Newman, President of Aurora Medical Center, and also Dr. John Leschke, Vice President of Medical Affairs with Ascension Mercy Hospital. And both are here to talk about the state of operations at the hospitals in terms of in relation to COVID-19 environment, talk about the availability of healthcare services in the community and preparedness. So with that, I'm going to throw it over to John Leschke. There's three Johns here, so we can't go wrong with any of them. So I'm going to throw it over to John Leschke, and he'll take 10, 15 minutes, as will John Newman, and then we'll have questions after that. So John, take it away.
Great, thank you, John. First of all, I'd like to just say good morning to everybody and appreciate you all attending. I think we've got some very valuable information to share with you this morning. And I'm very grateful for having the chance to be able to represent Ascension Mercy Hospital during this webinar. For those of you who don't know me, I am an Oshkosh native, and I grew up here in Oshkosh. I went to St. Mary's Grade School and Lourdes High School. I am an anesthesiologist, and I've been practicing anesthesia at Mercy since 1987. I became the Vice President of Medical Affairs in 2013. I'm very happy to share with everyone that Mercy has been working very hard to optimize safety for our community and prepare for the elements of this pandemic. Mercy does have a long-standing process of incident command and disaster drills, so things like this pandemic are things that we do prepare for in some fashion. However, as you all know, the onset of our COVID pandemic was something completely unexpected and really kind of unusual in its nature. It appeared suddenly, and probably most importantly, the very nature of the virus itself was something that was largely unknown to everybody in the medical community across the nation. In particular, we didn't know a whole lot about how contagious the virus was and the mortality rates and the treatment modalities that were possible for this. So naturally, that created a lot of anxiety for everybody, including healthcare caregivers, and a certain level of fear early on, especially before we had processes in place and kind of knew what we were doing. There was a general concern about being present in our hospital and what we were up against. So naturally, our healthcare providers were concerned along with the community. Very fortunately, as part of a large organization like Ascension is nationally, we were very quickly able to draw on the collective thinking and knowledge and experience of Ascension national and on a statewide basis also, and kind of pool our resources in terms of problem solving and so forth. And we got fast at work to address a number of priorities. Among those, of course, first and foremost was to prepare to care for our COVID and our non-COVID patients simultaneously. Secondly, to make sure that we were protecting our associates and our clinical staff at the hospitals. We needed to expand our capacity to accommodate a possible surge of unknown magnitude rather quickly. And then additionally, we wanted to enhance the safety precautions for all of our future patients and staff people to our clinics. Again, the benefit of being part of a large organization made that task much more easy than it would have been if we had to solve those things on a local basis. So our early activities really can be kind of broken down to a subset of actions. On a facilities basis, we immediately instituted entryway screening of patients to effectively route suspected COVID patients in a manner separate from non-suspected COVID patients. The obvious goal there was to avoid cross-infection or cross-contaminations of patients who we thought might have COVID and those who might not. We proceeded to create COVID-specific and non-COVID specific walled off areas in the hospital, including putting patients on separate floors where possible. And also we restricted access to the hospital to just a few entryways. We also early on began planning to expand bed capacity for anticipated potential surge. Part of what we did also at Ascension Mercy was to create a drive-through testing station just outside of our ED so that we could physically keep people from entering the hospital where possible and still get tested. And then probably equally importantly, for people who had to access our cancer center, we created a separate entrance for them so that they would not be even remotely exposed to COVID in their immunocompromised state. As far as the equipment needs, we were able to secure available personal protective equipment quickly. Initially, supplies were somewhat limited, but our collective efforts were able to get us sufficient supplies of masks and gowns, the N95 respirators that you've all heard so much about, and also create plans that would allow us to expand the number of ventilators that we would have on hand if needed. And then finally, we were able to increase our testing supplies going forward. In terms of what we did in terms of personnel changes, because we were no longer providing routine services at our hospitals and clinics, we implemented a redeployment program where people who had been working in other areas of the hospitals or clinics were reassigned to jobs throughout the hospital to help make our new workflows workable. The clinical staff in general was surveyed and to find out who among our clinical staff would be willing to step up and be redeployed in a clinical fashion as necessary. So for example, if we needed help in the ICU, we were calling on our hospitalists and our anesthesia personnel to help support the ICU efforts if needed. Some of our internal medicine and family practice docs who were in clinic settings were asked to possibly come to the hospital and support the hospital system if that became necessary. And we were very grateful that there was an overwhelming level of support from our clinicians to voluntarily step forward and kind of answer the call to service. And in addition to that, there were a number of policies and protocols that had to be developed relatively quickly. Again, those involved things like controlling hospital access and screening for all people entering the hospital. We had policies developed to preserve and conserve and reuse personal protective equipment. Enhanced testing policies were developed, and then policies that would limit visitors to the hospital physically and encouraged virtual visits for patients in the hospital. On the outpatient clinic side of things, naturally, routine visits decreased rather suddenly. We did implement virtual visits to try to keep potentially COVID positive patients out of the buildings. We We established some separate respiratory clinics so that patients who called in and were felt to have respiratory symptoms would not have to go to their normal clinics. They could go to a respiratory clinic and be screened and possibly tested if necessary. In the clinics themselves, there was an immediate attempt to reestablish traffic flows so people wouldn't be sitting in waiting rooms together, potentially contaminating each other and infecting each other. So patients were encouraged to call ahead for appointments, and patients' visits were staggered so that there was not a full queue of patients waiting in line to be seen. And a fair amount of phone screening was done to redirect patients as necessary to make sure that the clinics weren't being overexposed to potentially positive patients also. All of those things were done relatively quickly within the first couple of weeks. There were a couple of unintended consequences of the things that we did. And naturally, because there was fear in the community about the nature of the COVID virus, we quickly realized that a lot of people who actually needed care emergently or urgently were not coming to our emergency room. And even when they really should have, and we know that there have been people who became more seriously ill than they should have because they were afraid effectively to come to our ED. The clinics also saw a decrease in what we would consider to be normal maintenance care of serious illnesses like COPD, congestive heart failure, hypertension, and diabetes. So what that did was really create a potential for us to have more difficult patients going forward after those patients resurfaced. On the good news side of things, I'm very happy to share with you that we've had very few COVID positive patients at Mercy, and we've had some patients under investigation that we've kept for a few days, and then as they recovered, we were able to send them home and have them quarantined. We did have one patient who was intubated in our ICU for roughly 7 days, and he was treated very effectively. He was discharged, and I had the pleasure of taking care of him myself about a month after his discharge, and it appears that he's doing very well, and we expect him to have a full recovery. So we're very proud of that work and very happy for that patient in particular. At the current time, we have an ample supply of personal protective equipment. We have ample supplies of testing equipment, and we have a very high capacity to handle a surge if it were to happen, even though the trending now appears that may not be the case. Equally importantly, our providers are very confident that we are able to very safely take care of patients within our facilities without any significant risk of exposing patients to COVID in our facilities. And probably equally importantly, the healthcare providers themselves are very confident about their own safety and their ability to stay safe while at work. Early on, as I mentioned, the anxiety levels among healthcare providers were appropriately high. I think it's very safe to say at this point that for most of us who've been in the hospitals now for a month or 6 weeks, our anxiety levels are pretty much on the low level, and we're feeling confident that we are safe and that we can safely take care of our patients. So going forward, we know that we will not get back to the situation that we had in February this year anytime soon. So there is what we're calling to be a new normal, and that will involve increased testing for COVID more routinely than we had in the past, continuing to maintain all of the recommended precautions for safe distancing and hand hygiene and all of those things that you've heard so much about. We've, of course, implemented strict disinfection protocols for the rooms that are used in the hospital and effectively all over the hospital, things practice on a routine, predictable basis. And one thing, in addition, we expect to continue going forward is promoting the virtual visits with patients. None of us know how long the effect of COVID is going to linger, and we found out that there's a very high level of satisfaction with patients with the virtual visits, and so we expect that will be something that is long lasting and potentially a benefit that comes out of this for all of us. We do continue to expect that there will be some restrictions on visitation in our facilities, but that is an evolving thing, and as we see the numbers of cases trend downward, that situation will evolve, and we hope to loosen those restrictions appropriately as we go forward. We do have a plan to reopen. We are following the Ascension national and state guidelines, and it will be a gradual, incremental resumption of elective surgeries, elective procedures, and other services. And all of that is dependent on a continued downward trend of COVID positive patients in our region. And our region, fortunately, has had a very low incidence relative to southeast Wisconsin, for example. We will continue to monitor that data to make sure that we are not, beginning an uptick in COVID patients. And if that should happen, we may need to throttle back on reopening some of our services. But right now, we are progressing gradually and incrementally. So basically, before I finish, I have a couple things. You might ask, how can you help us? First of all, we strongly encourage you to continue to encourage social distancing, masking, and hand hygiene, as has been recommended by the CDC and other organizations. When you are allowed to reopen your business, we hope that you do that responsibly as guided by the CDC and the other state recommendations. Very importantly, we encourage you to encourage people you know and citizens of Oshkosh to resume normal accessing of our healthcare system. It's important that people not delay care, especially if they have serious illnesses, but it's also important for the hospital to resume its normal operations. We took about a 50% loss in revenues during this process, and just like all other businesses out there, we need to start regaining that revenue flow. It would be very helpful if you can help dispel the fear of people coming to the hospital. At this point, we believe we've optimized the safety of our facilities, and we're confident that people coming to our facilities are at a very low risk of exposure. It's also important that going forward, you will all support legislation that will support additional funding of healthcare facilities and systems. Again, we've lost a lot of revenue during this time, and contrary to some beliefs, there really is not much revenue that follows treatment of COVID patients. Also, to whatever extent possible, if you can continue to support national and state initiatives that will ensure that we continue to have adequate supplies of PPE and testing, that will be very helpful. Finally, Ascension Mercy is grateful to all of its caregivers and associates and the community support for all of our healthcare heroes. Ascension Mercy is very proud to have been able to maintain nearly full-time employment of our associates and nearly full pay for all of our providers and associates. We've benefited greatly from the leadership, guidance, and learning and best practices shared across Ascension nationally. More information about COVID and what Ascension is doing is available on the Ascension website through the CDC and World Health Organization websites. Ascension also has a social media presence on Facebook and Twitter. And I just, again, like to thank you for the opportunity to share with you what Mercy's been doing in the community, and I look forward to your questions after we hear from Dr. Newman.
Okay, well, great. Thanks, John. Appreciate that. Next, we'll turn to Dr. John Newman. And John, you want to take it away?
Excellent. Thank you very much, John. Thanks for the chamber for giving us the opportunity. Fantastic job, Dr. Leschke. With I think that, people always kind of ask, how are people doing things different? And what's the difference between Theta Care, St. Agnes, Ascension, and Aurora? And I would say in times like this, very little is different. We have been aligned, and even though we've been working within our own organizations, John and I have talked about, if we get an event, how do we share resources? How do we share talent? How do we share even beds and ventilators? Because what we found is somewhat a variation that it can occur, that this hospital over here 10 miles away is a very different experience what's happening in this hospital. And so, well, we're both fortunate that we're part of much larger health systems that quite honestly are working through a supply chain and an expertise in logistics that can support us. We also look to each other to say, if we need each other, we're going to be there for each other. So Oshkosh should know that, when we do our planning, we do our planning together. And if John gets cut, I bleed, and vice versa. So I'm John Newman. I'm a general surgeon by trade. Spent 20 plus years in Virginia with the Navy and then private practice. And then somebody offered me an opportunity out here in Oshkosh, Wisconsin, which was very exciting to me because I used to fly into Oshkosh sitting on my daddy's lap at the end of every July. So when they offered me the opportunity to come to Disney World and work, I said, let me come. And I've been here for 5 years and have just completely enjoyed and really love the way Oshkosh as a community wraps their arms around their healthcare team and professionals, and truly have never felt anything but absolute welcome for the physicians and nurses that we bring in. And certainly over the last 8 weeks, the recognition that the community has given our teams, we appreciate that. That makes a big difference. To John's point, yes, we were all very scared initially, but I would say we're scared when HIV came out. We get scared every year about the effectiveness of influenza. We get scared sometimes, if you even recall Ebola a couple years ago, as we were figuring out how are we going to care for these patients with them. But what has been consistent with the health systems and the true community benefit is you've got a collective group of people that have proven time and time again that they will step up and they will lean in. I tell you what, I'm not going to repeat a lot of the things that John said. I think the logistics flow of how to prepare is very important. And I would say that I would expect all of our health systems to prepare the same way. Maybe echo a few things. The white tents that you saw outside of some of our facilities fundamentally were for ED expansion overload, that in the event that we actually had too many patients that our EDs couldn't handle, then the thought was these kind of, people that weren't quite as sick could be cared for in these kind of expansion tents and be seen and evaluated, observed, and then probably sent home from there. And that way you could focus the sicker patients into the emergency rooms. Across a system, we certainly never had to utilize our tent, and across our system, we still only have a handful of those tents that are up and even working and running right now. So in Wisconsin, we have been fortunate. So obviously the situation's different in New York, and even our situation, and I'm sure John's situation is different in Chicago, because of the mass of humanity actually makes a difference in the rapidity of this spike. I don't think we're going to look back and say that we could have asked more from our state and our community to be safe at home, to be, safer distance, and to practice hand washing and masking and social distancing. I would tell you, I think Wisconsin as a whole has really kind of paid attention to those fundamental behaviors, because the behaviors we all want to, make sure don't leave this meeting today without knowing that if you wash your hands and you don't touch your face, there's a very good chance you're not going to contract this disease. And so everything else is a little bit extra protection, but nothing compared to let's keep our distance, let's wash our hands, and let's don't touch our faces. As we go forth and what we've done, just like John, we actually fundamentally doubled the size of our ICU, doubled the size of the hospital in the event that we needed it. if we needed it, that would have put us into a crisis mode. And quite honestly, nobody wants to practice medicine in a crisis mode. And unfortunately, we never had to. Much like John, we have had a continuous 1 or 2 COVID patients within our hospital since this started. Many people come in under investigation, and we test and we figure out, do we need to put them into our COVID units or not? We had the capability within the hospital to take an entire tower and turn it into negative pressure, which from an infectious standpoint just pulls the air and protects, the caregivers from the patients and the patients from the caregivers, and continuously recycles that air a little bit differently, which protects us. I think all of us, and during conversations with Theta Care and Ascension and St. Agnes, we have not had many of our own team members get ill. And within all of Advocate Aurora here in the Oshkosh Fond du Lac market, we only had 1 team member contract COVID. And that team member was in a community based and was actually furloughed at home at the time. So I think we're now 7 weeks into this. We're feeling very confident that we can walk into a patient with COVID's room and care for them. And there's certain things we would try to opt not to do. I don't think John and I would electively operate on a COVID positive patient until they'd gone through their healing phase with them. But we know that we can protect ourselves. We know that we can protect our operating rooms. We know that we can protect the community. Some of this is with social distancing. Some of the feedback that I've gotten, the community would appreciate if we would relax our visitor policies. And I totally appreciate kind of the dichotomy of the different decisions when we're saying restrict our visitors, but still feel comfortable to come into our health systems. These are risks that we think we can contain, but mostly what we don't want to do is to have an oops, right? 100 attaboys don't come close to one uh-oh. And when we look at how to restrict our visitors, we really are trying to say, how can we protect our patients' families, protect the nurses, and protect the caregivers here on the team. And so I think we're getting more and more comfortable with that, but I know that, how might we be able to elevate those restrictions is pretty important. The logistics is logistics. That's the professionalism of these organizations. We were flying 747s to China to pick up and inspect our PPE before we flew it back. Dr. Leschke and I both have great supply chains that support us on a very large scale with them, but then we also were very conservative how we utilize these N95 masks and everything. We're still very much into the conservation posture of don't waste it, because nobody here is certainly comfortable that this disease is gone. I think when you look at the curves of this disease, I would tell you that as we learn more and more about coronavirus in particular, initially we were fairly excited about some of the opportunities. And I would say a little bit was false hope, because we have never been fantastic on treating a virus. We have some antiretrovirals for HIV. We do have some anti-influenza medicines that decrease the duration of the disease. But for the most part, it is very difficult to come up with a treatment management regimen just to treat viruses. And so the hydroxychloroquine, the remdesivirs, the immunobiologics to suppress the immune system, they all had hopes, but quite honestly, we all had some cautious optimism because they've never really worked in the past, nor did they really work with SARS and MERS, which are also coronaviruses. And what we're finding now is that really the Plaquenils, the hydrochloroquines really didn't make a huge difference. The remdesivir may shorten the duration of the hospitalization, but doesn't appear to be a great improvement of survival. With the one thing we're all actively studying now is if John Casper gets COVID and he fights it and wins, and then I take his serum and then transfuse it into a new COVID patient who is struggling, there right now appears to be a little benefit for that. But when we say a little benefit, that's where all the things that we're doing now are doing in proposed clinical trials to add to the intellectual knowledge to really say, what is the benefit of this? And so COVID's real. I think we've all heard it, and the death numbers are real. The disease is serious. Once you survive the disease, you really can go back to a fairly normal life. With it's such variations from relatively asymptomatic to sick to very sick to people that immediately go straight forth. and get overwhelmed and die, which bothers us, but it's not really the virus that's doing that. It's our reaction to the virus. And so we keep playing with the human body's response to such. I tell you what, I think that, you know, this whole concept of virtual medicine is fascinating, but we're also cautious about saying none of us have been to virtual residencies and fellowships. And while there's a lot of things that we can do virtually and our patients would ask us to do virtually, that we really need to keep asking the same questions we did last year about, is this good medicine? What are our outcomes? And does this make sense from a value-based scenario? We had a goal in January of doing 25,000 visits within Advocate Aurora Health. And I thought that was optimistic because last year we'd only done 2,000. And I think the day before yesterday, we did over 50,000. But the question we really keep asking ourselves, is this optimal medicine? We don't want to just create something that's okay in these times. If we're going to change how we're delivering healthcare, we really want it to be for the better. And so I think this is something that collectively, that the Auroras, the Advocates, the Mercies, the Ascensions, and the Thetas are all doing together. But this is something we're learning on our own, but you're teaching us. I think something, you know, John Casper, that we're learning about our patients is our patients don't mind the virtual experience. I think you're consumers to the Chamber of Commerce. Obviously, the internet has proven to you that they don't mind a virtual interaction with them. Here's what we are learning, though, that I think is pertinent to anybody who's running a business that wants people in and out of their business. They do expect us to be conscious and to be thinking about safety. So when they come into Mercy or Aurora, there's going to be hand sanitizers everywhere, and really the behaviors we need are people washing our hands. And that would be the same if I were in, you know, a small business. The patients really don't want to be in our waiting rooms. I can't imagine they're going to want to be in your waiting areas. And so our patients, when they do come and interact with the health system, really expect and have a preference to say, just don't make me stand around and wait with a bunch of others. That we actually deal with healthy people, trying to keep them healthy, and sick people trying to improve their health. And so they also are asking us to separate these patients, whether it be a pediatric clinic to take care of the sick kids in the afternoon, or internal medicine clinic to say, hey, for that fever, let's see you later in the afternoon after all the non-febrile people are in here. Or quite honestly, let's link virtually and ask the question, what can we do to help you? And if we need to see you, where's the safest place to see you? And so those are the things that we're changing. When you walk into our hospitals, it is different. And so if you haven't walked into the hospital, that you'll find that there's screeners that are asking you questions, that are checking your temperature. If you don't have a mask, you get a mask, and everybody in this facility is walking around wearing a mask. We're trying to limit the travel to and from the clinics and to and from the CT scans and the MRIs, and how to keep that socially distanced as we go forward, because we've learned that's actually the expectations from our patients. So a lot has changed. The waiting areas don't have chairs anymore. They've got chairs every 6 feet as we've separated them around. So don't freak out when you come into the healthcare setting, but realize that this is really in response to what our customers, consumers have asked of us, to say this is what we expect of you, which I think is going to be fairly similar to the expectations that are going to go forth for any businesses moving forward. And so, you know, I hope that as a collective that you hear that your health systems have said thank you, because the whole purpose of the Safer at Home was to not overwhelm the health systems. In Wisconsin, we did not overwhelm the health systems. In Chicago and Illinois, we came close. But in New York, we actually really did push the limit, you know, beyond some of their capacities. And so I think we've achieved, and all we can say is thank you, because I think it's the behaviors of our communities that has protected that. That doesn't mean that we fundamentally have less patients, because I think this virus is still fairly infectious, and we just may see it gradually over a longer period of time. But I think our health systems are feeling much more confident that we're going to be able to manage, you know, our future, however we kind of restructure, you know, getting everybody fired back up, engaging in the community. But we're feeling confident that we're going to be able to handle it, which is, I think, what the community on this call, John, really needs to hear, is that, are you guys pretty confident that you can handle this? And the answer to that is yes. And so without further ado, I'd say open it up for questions. Dr.
Well,
Leschke, anything I forgot?
Well, I think we'll probably hit you on some of the questions here. We've been getting questions online and a few offline here, so I'll try to address as many as I can. In some cases, you've talked or you've addressed it a little bit already, but we may ask some expanded questions. You know, back in March when this all hit, shutdowns occurred. You know, we didn't know a lot about what COVID's really all about, and I think the reaction was probably appropriate in terms of distancing people and shutting things down. But, you know, since that time, we've learned an awful lot about, you know, what's happening, how people are responding, who the more vulnerable populations are, and that sort of thing. So from your perspectives, I mean, what should the community do? I mean, the community wants to be rational. The community wants to be smart about this. They don't want to put anybody in jeopardy. However, we have to get on with lives and businesses and that sort of thing. So, you know, what have we learned in terms of, you know, is this really just another, you know, bad flu season and that sort of thing? And so what's your thoughts around that?
John, I'll let you go first. I've been talking too much.
Yeah, so I guess, you know, first of all, you know, I echo all of Dr. Newman's statements about the status of things in the community and how we are willing to work together, et cetera. But I think, you know, there still is a lot of unknown about this virus. And even though those of us who are really anxious to kind of get business back to normal and want to kind of characterize this as just another bad flu season, I'm not sure we can say that with a high degree of confidence at this time. As the data continues to come in, I think that becomes clearer and clearer. We also recognize the financial impact on the economy and how devastating that is, you know, in a manner similar to health problems. So, you know, we are supportive of reopening, you know, according to the CDC guidelines and the state guidelines. We're hopeful that that can move along quickly, but it's really kind of not our job to supersede the guidelines from those other organizations. You know, I think the bottom line is, as healthcare providers, we feel that we're confident in our ability to reopen. All of the usual things that have been recommended in terms of distancing, masking, and hand hygiene, those things, of course, apply to all businesses, recognizing that not all businesses are equally amenable to being able to do those things. So I think it will be, you know, a gradual process for all of you, and I think there will probably be, you know, guidance coming forward to help businesses reopen when that is allowed.
I would say the other things we do know about this virus, it's pretty infectious, about the, we call it R factor of 2, probably 2.4, which means that it's going to affect about 2.4 people, you know, for everybody that gets infected. And so that's still pretty high. And so it's hard to slow that down. So when you see these things spike up, then our job working with the health department is going to go to where it spikes up and try and look at the contacts, who's been interacting with this particular patient with COVID, and how can we mitigate those contacts and isolate those patients to the best of our ability. We also know that there's a good significant, about 15 to 20% of these people do get very sick and wind up in our hospitals. It is not just for the elderly. While they do not tolerate this disease very well, their mortality is up around kind of the 15 to 20% if they get it. And so for our elderly, if they get this disease, it's a big deal. We are seeing kind of post-viral kind of, you know, anomalies popping up that we've seen with previous viral exposures in our children as well. And so this is not one that I would say, let's let the kids all get, and they'll help us build up a herd immunity and protect us to slow down this virus. I would much rather have my child vaccinated against this virus than actually get it. Although I think we're not going to have many children die from this. I think some of the sequelae from the inflammatory components of this virus, we're learning more in the last couple of weeks, John. So I would say, you know, which people want confidence, but we are learning a lot about this virus. I will tell you right now, there is no magic bullet, and I don't expect there will be a magic bullet on how to treat this virus or many of the other viruses. So we support the patients and the immune systems while they get themselves better. but there is no magic medicine out there that's going to kind of help us fight this. And as we wait for a vaccination, which there's not a whole lot of confidence that with coronavirus vaccinations, that this virus won't mutate enough toward next year, that the vaccination we create this year may not even be effective for whatever it mutates into next year. So I would say this is one we want to avoid with, if the vaccination comes up, I think everybody will be lined up and hope to get it. You know, one of the bigger questions we all have is how many people actually had it? A lot of people on this call were sick in January and February and were like, I wonder if I had coronavirus. And I think we'll be able to answer that question with some serology testing, which is available. But right now, we're trying to understand really what's the value of that serology testing. And so we're learning a lot about this virus, but I think we all know enough about it to say you don't want it. And so it comes back to, I don't think we're getting this virus just by breathing the air. We're getting this virus from touching surfaces where somebody did have it on their body, or they sneezed, it went to a surface, we touched those surfaces, and then we touched our faces. So we've learned enough about it, how to protect ourselves, but I can tell you, you don't want this one.
Question came from the audience here. You know, we're all asked to be staying at home. We're being asked to wash our hands, disinfect. But the question is, are we actually lowering and diminishing our immune system by doing that? And a follow-up question on that also was, are more people getting sick? Will more people get sick? Are you anticipating that when we start going back out again?
So I've been aware of some of those discussions that are out, you know, in the media and on the internet and that sort of thing. And I think there's a lot of speculation about that. I don't have any particular scientific knowledge to really respond to that. We do know that in general that, you know, being exposed to germs and viruses, bacteria does, you know, help your immune system kind of rev up to fight other things. But I think it's, you know, speculative to think that by washing your hands and doing the other recommended things is somehow going to increase your vulnerability to this. And for the time being, at least, I think the most prudent thing to do is follow the guidelines that are out there.
But this question has been asked for decades about, you know, does my kid really need to eat a pound of dirt? And, you know, the answer is probably, you know, because they need to get sick as kids and they build up their immunity as we grow up. So our immune systems have a memory throughout life. So as we see things in our immune system, the memory we hold into it will protect us against future diseases. But I think, you know, even when we started putting kind of antibacterials into our soaps, people were asking these questions about, is that a good thing? And I think that fundamentally we have proven that good, safe hand hygiene is important. I would not say go out there and eat your pound of dirt and touch as many surfaces as possible. That's just not something I think that would bear out.
Question here. Do both of you believe, or, you know, both answer this yourselves, Wisconsin would be better off to track the number of COVID-19 patients against the number of beds versus the number of people testing positive for COVID-19?
I'm not sure I totally understand that question. I think really if we talk about the testing, what is it teaching us? I would tell you this is where, I mean, I think both John and I and all the other health systems have been saying we need to test more people. And when you want to do a mass testing, what you're trying to understand is what's the incidence of this disease right now? And so testing on a mass scale right now would tell us who is actually shedding the virus at this particular moment. So it'll give us a point picture in time, and it doesn't really give us a trend. The testing, when we stick these Q-tips into people's noses, we're pulling the Q-tips out. And if they have even 2 viral particles on there, we're able to run it through a polymerase chain reaction to say, yep, they've got the virus shedding. It could be a dead virus from when I fought this thing 2 weeks ago, or it could be an asymptomatic live virus that I'm shedding. We don't know what type of virus, alive or dead, I'm shedding, but I do know that there's at least 2 viral particles. And so when we look at community-based testing, the only thing that's going to give us right now is where are you at right now? And it would be different than South Suburban Chicago to Milwaukee to Oshkosh, Wisconsin. So if you just test the state, you can't really get the information you need. What the Department of Health wants to know is what's the incidence of active disease right now. That doesn't tell you who's had the disease in January, February, and it doesn't tell you who's immune from the disease. It tells you who is actively shedding viral particles right now. And so if we tested everybody in Oshkosh today and had that answer, you know, then it's okay, this is how many people are shedding the virus today. And then in 2 weeks from now, we'd be scratching our heads and say, we want to test them all again because we want to see what's changed. And so that strategy doesn't make the most sense because it's just mass testing, and it's only going to comfort you for about 72 hours that you really know what's going on in your community, which is why the health departments say, you know, that would be helpful at least initially to give us some idea. But what we really want to be able to do is respond quickly to when somebody comes up with COVID, that we could go do the contact tracing for those people. And that's where I think the health departments are going to need help from the Auroras and the Ascensions and the Thetas to quickly respond to that, to contact tracing and control that spread, because that's what has been proven successful across the country and the world with them, and historically time and time again. So infectious diseases, the etiology and how we manage them really hasn't fundamentally changed, John. So I would say right now we're probably going to do some larger scale testing just to get a quick snapshot. But once that snapshot's done, that's not going to comfort us for a whole lot longer. And then what we're going to have to come up with and say, all right, when people get positive, how do we contain and control? And might there be a serologic blood testing, which means now a needle must go into my arm, you must pull my blood out, and you're going to look to see if I have the antibodies against COVID-19.
John, any thought about that?
No, I agree with Dr. Newman on that. There's still a lot we don't know, and even with serologic testing, we're not sure what the implications of somebody having had the disease are in terms of them being immune or partially immune or that sort of thing. So I feel confident that we're going to learn more and more in the upcoming months as more data is collected. But for the time being, that's kind of what we know.
Right. We've seen a lot of masks around town lately at stores, people driving around. Early on, they said, you know, don't worry about masks. That's not going to, you know, help you. Now they're advising everyone wears masks. I mean, certain stores you can't go in without wearing a mask. So, you know, do masks with vents to really provide proper protection for for that individual who's wearing them, and are they protecting those people around them? What's thoughts about that?
I mean, this mask protects me about 95% of the viral particles that if I walked into a COVID positive patient's room, this is going to protect me 95% of the time. This is an N95 mask. It goes a little bit tighter, a little bit snugger, a little thicker, and that's going to protect me 99% of the viral particles. So there is a little benefit from the N95 to this. But people walking around the community wearing masks, what that protects everybody from is if they cough or sneeze and they have the virus, those particles are coming out, sitting on the surfaces of what we're touching. And so the only benefit is really so if they cough and sneeze, that they contain that cough and sneeze within their mask, and the vent is still going to contain the viral particles. So I would say there's still a protection, even a handkerchief is going to protect some of the viral particles that come out and settle down on the surfaces that if we touch and then we touch our faces, that's how the disease is transmitted. Dr. Leschke?
Yeah, I agree with that. I mean, you know, it is certainly imperfect barrier, but it does, like Dr. Newman said, minimize the droplet spread if somebody coughs or sneezes. And especially if we're not maintaining social distancing, you know, if you've been to the grocery store and you're coming, you know, typically within 2 or 3 feet of people inadvertently. And so in theory, at least, it does provide that level of protection. It's also prudent. I think it's also symbolically beneficial in that it's a reminder to everyone to continue to exercise precautions. And so at this point, there's no good reason to not suggest that people continue to wear masks where appropriate.
John, I think you're muted.
How about now?
We can hear you.
Hear me?
Yes, sir.
All right, good. I have problems with this computer. But as we test more people now, it seems the occurrence seems to be higher, even though the percentage of those getting it and not getting it is roughly 10%. But if we were experiencing this virus back in January and February of this past year, so what's your thought or what's your estimate about how many people may have had it that weren't even tested?
I would say the majority of people haven't been tested. And so I think that right now we know that we haven't tested but a couple percent of the population. And so the only way we're really going to answer that question is with serologic testing. And so that's going to have to be done on a fairly large scale to say, let's at least sample their blood. Do they have the antibody? Then we can look them in the eye and say, at some point in time, you got exposed to COVID-19 and you've created the antibodies for it. To Dr. Leschke's point, we don't know if those antibodies are totally protective yet, if they're immune, if they would then walk into a patient with COVID positive without a mask on. And there's even some data, and because it came from the University of Wisconsin, I think I would, repeat it, that the virologists there are really looking at some of the quantitative DNA differences in some of the viruses. And we actually have two different viruses that we're seeing down in the Chicago, Milwaukee area, and it's a little bit different than the Madison area. And so while most of the viruses are similar, the question comes up, if I had the Madison virus, am I going to be immune against the Milwaukee virus? And those are the questions we don't know. But I don't think any of us are going to be able to answer that question, John, until we actually have, serologic antibody testing that we rely on, because a lot of these tests have come out. A lot of them have come from China, and they said, hey, we're 85% good at predicting antibodies, and we're finding that the accuracy of them is maybe in the 20 to 30%. I think Ascension and Aurora have both developed their own testing and have confidence that if we are doing a serologic test, that we've got a good test. But right now, the only people we're applying that test to are the people that want to donate blood as a convalescent serum to treat other patients and clinical trials, because right now, there's not an overwhelming confidence as a clinician that any clinician really can have about this test. We don't know what it's really telling us yet.
John, any thoughts on that?
No, I agree. We have just recently had serologic testing available locally, and we expect that we'll be doing a lot more testing like that. I know that we're all kind of anxious to see large numbers of people who may have been infected and asymptomatic or recovered, under the theory that there's some sort of herd immunity being conveyed by that. But again, I don't think we have hard science to conclude that, even if we did have the numbers of people who are serologically testing for antibody presence. So I think there's going to be a lag, and hopefully it won't be a long lag, but scientists across the nation will be providing that sort of information to us as it becomes available.
The Winnebago County Public Health Department reports COVID cases on a countywide basis. Do we have any idea how many positive cases we've had in Oshkosh?
76 as of the afternoon.
76 in Oshkosh?
In Winnebago County.
Okay, do we have anything specifically for Oshkosh at all, or?
I tell you what, I think from, John knows his numbers. I can tell you that we have tested about 20 people to be positive, but do I know if they came from Oshkosh proper, or maybe they came from Monroe or even Wautoma? I don't think I can tell you with any certainty what our numbers have been that we've tested positive. But all these numbers that we do test, even the negatives, we do contribute to the pot of intelligence that the state and the county are looking at. So I think the Winnebago County is probably the most myopic kind of finger on the pulse we're going to have. But I still think it's giving you a good trendable kind of, idea of what's going on with COVID in Winnebago County.
Do we have any idea of recovery? I mean, I've asked the public health officials many times about, well, we report it this way. Some people have recovered from that, but they don't, track that, and they don't report that. Do we have any percentage or?
Well, I think right now we know that only one person's died from it in Winnebago County. So the assumption is that everybody else is recovered. Could there be somebody that, was found dead at home that we didn't necessarily do a COVID test on, or somebody who, may have had other comorbidities that passed away either at home or in a skilled nursing facility, or even in our hospitals because they weren't under investigation or weren't tested. There's a possibility of that, but I would say since, at least kind of the second week in March, we've really been trying to do some testing. And so we've got the number of positives and we've only got one fatality in Winnebago County that I know of that's been recorded.
Every day, people are getting emails, videos on YouTube, a variety of different things. And, you get them, they say, share this with as many people as possible. And it always seems to be, MDs from across the country talking about, their experiences, what they see, what they're reading. And it all seems to be contradictory to what the CDC is advising. Who, as just people, who do we believe?
So that is a topic that's, that I think we've all been exposed to. And in fact, I was watching a YouTube video yesterday and people were asking my personal opinion about that sort of thing. On whether anybody appreciates it or not, there's a long-standing tradition in medicine that we do not, make scientific conclusions based on anecdotal stories. And so, the tradition of double-blinded studies have been the gold standard for, scientific conclusions and peer-reviewed articles and that sort of thing. It's very, I think, seductive to listen to some of these videos and YouTube clips and want to buy into whatever theory is being propagated. I personally have no way to decipher the legitimacy of a lot of what I'm seeing, as a physician. And so it is very difficult. And, again, I think whether we like it or not, we have to rely on the national organizations and presume that there's no reason for them to not want to be sharing the truth with us.
It is exhausting though, isn't it, John? I mean, because you do get a lot of contradictory, but I would tell you that our world in Oshkosh is definitely different than the world in Brooklyn. And so don't try to compare those two apples either. And so, even within just our organization of Southside Chicago versus Northeast Wisconsin, I would not answer a question the same way if I was at Christ Hospital that I would here in Aurora Medical Center, Oshkosh. And so I appreciate that it's mind-numbing that we get these different answers, but I would answer the same question two different ways if you ask me from what I'm doing in Aurora Medical Center, Oshkosh, and what I'm doing at St. Luke's or what I'm doing at Christ Medical Center. So I would say there is wisdom to the crowd and you listen to them and you try and decipher it. But, John and I were taught, don't be the first one to jump on something, but don't wait around to be the last either. And I can't tell you, you got two gray hairs here, right? So we've all jumped on something we thought was a good idea. And after one good study and the second good study came back and completely refuted it. So those of us that have been doing this for a long time are somewhat cautious as we interpret kind of what we read. And it's got to, one, make sense up here, but second of which, we want to see some confirmatory evidence from not just one study, but probably 2 to 3 and then you probably are getting closer to the truth.
Okay. A comment that came in actually from David Zerby. Apparently the Winnebago County Health Department website has a COVID dashboard that shows locations of diagnosed cases in the county. Currently the number in the city of Oshkosh is 37. So,
well, thanks, David.
Yep. So one last question. We're hitting the 11 o'clock hour, and something I think is on everybody's mind. I'll throw it out to both of you. Is the virus here to stay?
People keep asking, the SARS burnt out, MERS burnt out, and they were two bad coronaviruses, actually worse than what we're seeing with COVID-19. The thought is maybe like influenza burns out in the summer. Some of the equatorial countries in the world are being affected pretty badly right now from COVID. So I don't necessarily think that there's a predilection that the virus doesn't like sunlight or doesn't like heat, because what you're seeing across the Sahara Plains of Africa would suggest that it's doing just fine in the heat. I would say we'll follow the data. I mean, I'd just be guessing and trying to come up with a prediction. SARS and MERS did burn out. And so I would say that for that alone, that gives us some hope with but what we're seeing right now, that China is still having a few cases pop up, and now 6 months into it, you know, I would say this is probably one that I would suspect we're going to either reach herd immunity, or we're going to find a vaccination to get us up to herd immunity. And we're not planning for it to burn out. We are planning for it to stick around.
Okay. John, I don't know if you're still with us. I see you're trying to reconnect here, but there he is. Oh, there he's gone. Anyways, let's we'll wrap this up. We're at our end of our time here. So, gentlemen, thank you very much. Very informative. We appreciate both John Newman and John Leschke joining us, and this is very, very, very informative. We are recording this, so this will be sent out to the membership if you for those who haven't had a chance to see it, or if you want to see it again. Next week, we have a topic is education. We have our Chancellor, Andy Levitt from UW-Oshkosh, along with Superintendent of Public Schools of the Oshkosh Area School District, Vicki Cartwright, will be talking about the state of schools and what they see in the immediate, not just currently, but the future coming into the fall semester here. So, you know, we are preparing. We are talking to our members about return to work. I think that's going to happen, whether it happens before the 26th or after the 26th. At some point, there will be a return to work. I saw that John Newman sent me some data about best practices on return to work. As a matter of fact, that'll be very helpful, because we're working on that, on a document right now that we look to share. And on the 15th of May at 11 o'clock, we're doing a webinar on those best practices to keep your workplace safe. So be looking for that. Again, John and John, thank you very much for joining us. And we will see you next Thursday again for our virtual town hall meeting. Thank you.